Thank you for joining us for this special series of This is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health and Humanities. Welcome to This is Getting Old. I'm your host, Melissa Batchelor, and today we're going to be talking about the age-friendly health systems and the 4M's framework, specifically around what matters. So what matters means is that we need to know what's important to an older adult so that we can align care to those specific health outcomes and the care preferences that are including, but not limited to, end-of-life care and across all care settings. So today I'm joined by Dr. Tahira Lodhi. And before we begin, maybe you can introduce yourself and then we'll dive into what matters as a key component of an age-friendly health systems.
Hi, I'm Tahira Lodhi. I am assistant professor in the Division of Geriatrics and Palliative Care at George Washington University. In this capacity, I've been working here since my fellowship over the last 9 years, and my major passion is teaching from classroom to my patient interactions by the bedside in the hospital and in all levels of long-term care. So, and as well as hospice. So I see patients across the entire spectrum of geriatrics and palliative care.
All right. And and it is important to know that regardless of where this healthcare encounter occurs, I mean, that's part of being an age-friendly health system. So this isn't just for people that are in the hospital. So what are some of the when we're thinking about what matters in the context of healthcare, why is it so important as we age?
It's very important because a lot of times I think the first reason I feel is a lot of times we as providers kind of lose sight of, I can sit here and prescribe whatever I want, but if my patient is not taking it, then I don't change anything. The outcomes do not change. We cannot lose sight of that. So to create that partnership with your patient, it's very important for us to know as providers what is important for that patient. Is my patient open to taking a medication more than once a day? Is my patient open to taking a medication that takes him to the bathroom all the time? Or what is important, or the quality of life is more important to my patient. Spending time with the family is more important to my patient. Being able to go to a grandchild's game is more important to my patient, and they don't want to rush to the bathroom all the time. So in all different settings, that what matters is very important. Not only that, but also self-rated health determines a lot of outcomes for our patients. If we don't ask our patients what matters to them, we won't be able to get an answer to that question of their self rating of their health. So all of that plays a role into what matters for our patients.
Yeah, I think one of the classic examples that I always think about when I think about what matters is I had a patient that I was, or a resident in a nursing home that I was taking care of. She had end-stage renal disease, was blind, except that she could see if she held like her paper like over here, and she was a full code. And I'd had the conversation with her about her code status several times. And so I was like, okay, well, it's time to have that conversation again. So I go in and begin to explain, you're a full code, you're on dialysis, like here are all the different things. And at the end of it, she goes, well, I didn't get anywhere with the code status, but I said, is there anything else I can do for you? And she was like, yeah, give me that piece of paper. And so she takes the paper and she goes, today is the Shriner's fish fry and I want some fish for lunch. I was like, all right, so that's my job today. I'm going to go get her, some fried fish from the Shriners Club.
Absolutely.
Like I probably should have just started with that. Like, what do you need today? So it's really about, as providers, sometimes putting our agenda like behind, that's our agenda doesn't matter so much if the person's not willing or ready, to talk to us. So if it is a student or a new provider, like how would you even begin to have the conversation? Like what are maybe some of the questions that you could ask?
So as a provider, first thing I need to keep in mind is this may not be a conversation that I will complete in one visit or one sitting. The important piece is to start having those discussions. Be open. The more open you are with your patients, they appreciate it more, and it would help them. Maybe they haven't contemplated those questions before. And so start having the conversations about as simple as what is most important to you? What can I do for you as a provider? What do you want me to do to help you make your quality of life better? Just even starting out with that conversation, and not necessarily an end of life conversation, that would probably open up your patient more. And remember to have this conversation repeatedly in several visits as your relationship develops with your patient. Keep your patient's surroundings in mind. Um, Ask them about their support systems. Ask them about, if they miss a medication dose, delve deeper and see why it's happening to them, so that they having these conversations at a human level with your patient is very important. Keep in mind, your patient is not the labs or not the diseases or diagnosis they have. This is a human being who wants to have a conversation with another human being.
Right. And I think a lot of times it's almost like you have two different groups of people. There's a group of people that they want you to do everything. You want you to do every test, and then it's, once you do the test, you have to figure out what you're going to do with those results. And so that was often, a conversation to say, well, what is your end goal with having all this aggressive treatment? And then you have the other group of people that's like, yeah, I know, that I'm dying, but I don't want to really do much about it. And, I actually have told people before, I was like, if you want to live, you should probably just go to hospice, because when you go to hospice, we take off a bunch of medications
Right.
and most of those people, live. And so it's about your quality of life, what's your end goal, and even having that conversation, with families also.
Right. And, we have data to say people live longer on hospice. I
Mhm.
think, it has to do with their quality of life, taking away all those medications that are probably not helping at this point. You mentioned earlier about your patient who wanted fried fish. I had a patient who said, you know what, I am not going to eat anything but fried chicken. And she was on hospice. And the nurses said, no way, she's hypertensive. She's supposed to be on a low salt, low cholesterol diet. And I actually wrote a nursing order to say, let her have fried chicken. I'm so glad
Mhm.
I did it, because she died 3 weeks later. And if she
Right.
didn't have that chicken, I would not feel good about it today.
Right. And I think that's where kind of the balance between, like, families, providers, and the older adult, having this collaborative negotiation to say, here's where we're at, in this process. I mean, my great grandmother was the same way. She had heart failure. Last time I saw her, she wanted, a shake from Hardee's. And I was like, I'm going to go get it. I don't, if she might be on a fluid restriction, but I don't think that she'll be here much longer. And she died the next day. And it's like, so, and in some situations, it is about quality of life, and the simple pleasures of life, that do have to be considered, and talking through with people, how do you, it is time to liberate someone's diet, when you're 40 years old and you have diabetes and you have high blood pressure, yes, you need to monitor your salt and your sugar. When you're 89, you know, might not be quite as important.
Exactly. Exactly.
So, we had started to talk about some of the other things that might be important, to somebody. So, what are some other things that might be more important to an older adult than being in the hospital, or all the time?
Right. So being with family, being in a familiar environment, um, being able to walk their dog daily, um, be able to communicate, especially in this COVID setting, communicate with their grandchildren or their children who cannot see them very frequently. That that may be what matters to your older adult patient right now. They may have travel plans. I have had a lot of patients in assisted living settings who are still traveling, taking cruise trips on a regular basis, and that's what determines their quality of life. I've had patients tell me, if I am not able to wash myself, that life after that is not worth living for me. There have been others who said, I want to live. I want everything done so that I can have support my spouse, for example, or be with my mother. My patients in their 70s are taking care of their older parents in 90s, or who are centenarians. So birthdays, anniversaries, holidays, they're all other things that may be very important to your older patient. So make sure you have a conversation about that to your patient.
Right. And I think to keep in mind, like, it's not like the thing that matters to you most is going to be the same at 40, 50, 60. And sometimes it's not even the same thing that you want from day to day. And so it's okay to continue to have the conversation so that we can figure out what's important to that person in that moment, so that we can try to provide the best care possible. So, but if there are certain things that are really important, what are some different ways that we can communicate that to the other members of the healthcare team?
So that's a very important piece, so that all the good conversation that you've had with your patient already doesn't get lost. So it's very important to document it, especially in your electronic health record. Make it a part of your care plan. When you organize it as 4M's, it's very easy for other providers to know exactly which part to go to when they are trying to sift through the medical records. So putting it in a place where other providers can see it easily would be very important. But other places where you can put it, it could be a preferred name that you put on a whiteboard for your patient in assisted living or in a nursing home setting. What are their preferred pronouns, their favorite foods or activities they like to do, what gives them comfort, phone numbers for their loved ones on a whiteboard in their assisted living room, apartment, or their nursing home room, or even if they're living independently, teaching your patient or the caregiver to record these things and put it in a place just in case of an emergency. Other emergency personnel can reach them and contact their family members if needed to. Those would be important things to do so that other members of your team are on the same page.
Right. And I think in a hospice situation, the one thing that they definitely ask you to do is to put like your what's called the golden rod, or your, do not resuscitate order out in case someone panics and calls the emergency squad to come, or rescue squad to come get you.
Very important in the assisted livings, for example, and in Washington D.C. It is to be put on the refrigerator. That's where EMS looks for it. That's what I'm told. I'll share with you one of my patients who was 104 years old and cognitively intact. She had a lot of physical debilities, but she was cognitively intact. Somebody else made a phone call from that assisted living facility for 911, and they gave her her apartment number. So lo and behold, they come and they pick her up. She kept telling everybody, I don't want to go, but nobody realized. And so until later on, I was contacted and I told them she's doing fine. Things worked out. But it's important to have that sort of information so that emergency personnel who don't know the patient, and they can access that information and we can avoid an adverse outcome.
Right, because and that's particularly important if what matters to that person is for them to be able to die at home. That we allow that opportunity and to decrease confusion.
Right.
And so any other other considerations that we should think about?
So always, again, thinking around along the lines that geriatrics and palliative care is always interdisciplinary, and there's always a team that is taking care of your patient. It takes a village, and that team includes not only your patient but their family members and their caregivers, and make sure they are a part of this conversation. For cognitively intact patients, I always encourage them to talk to their family members and let them know about what matters to them. So in case they are not able to talk for themselves, their advocates can. Of course, we as providers should be advocates for our patients in all different settings. For our patients who are not cognitively intact for any reason, maybe acute change, maybe chronic memory deficits, then their next of kin or power of attorneys should be aware of what matters to their patients, so they can make appropriate decisions for our patients according to what our patients want and not what we dictate for our patients.
True. Okay, well, thank you for being with me today to talk about the 4M's framework and what matters. All things that we need to be very aware of as we move towards widespread age-friendly health systems. So please be sure to check out the overview of the Age-Friendly Health Systems podcast with Drs. Alice Bonner and Terry Fulmer, and the other podcasts related to the remaining 4M's, which include medication, mentation, and mobility. Thank you for joining us for this special series of This is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health and Humanities.